So then I'm going to go ahead and hit admit all and let people start flooding in and getting comfortable. Hello, everyone, and welcome. We will get going in just a few minutes here. I like this. Some of you have started dropping where you're from in the chat. If you want to share and just say hello and let us know where you're coming from in the chat, we would love to see where people are hailing from. Good morning, everyone. We're sharing where we're from in the chat if you would like to share that. And we still have a pile of people who are rolling in. We'll start in just a few minutes. Looks like we're getting some folks from Caldwell, Meridian, Boise. Dr. Desai is somehow getting internet service in the middle of the lake. Not sure how that works, but that's great. Okay. So I'm going to get us rolling here just because I know that we do have a lot of content to cover today. So I'll make sure to just drop anything that individuals who are still rolling in miss into the chat, but welcome to our little pop-up event that we've got going on covering mild cognitive impairment and dementia this morning. My name is Hannah. I'm the operations manager for the Idaho Caregiver Alliance, and I'm just going to run through some really quick housekeeping items before I pass it off to our presenters for the day. So as all of you should have been informed when you came into this Zoom session, we are recording So we are recording this session so that we can share this with anybody who couldn't make it today. So this recording will be available on the Idaho Caregiver Alliance website. As soon as we're able to get it posted, it'll go out in our newsletter, and it'll probably go onto our social media pages as well. So when you just love whatever you hear today, you can go back and watch it as many times as you want in the future and share it far and wide. On Zoom, like most meetings, we do ask that you keep yourself muted. That way we're just limiting any background noise or distractions, and we're not getting any echoes or anything like that. And we do have our chat feature, which I'm hoping most of you are fairly familiar with on a Zoom platform. If you're not, that chat feature should be either at the very top of your screen or very bottom of your screen in like a little message bubble that just says chat. We really want to keep today engaging. So if you have any thoughts or comments or stories you want to share, questions, anything like that, that you just want to drop into that chat, we'll do our best to engage with those, to answer your questions, and get to those as soon as we can. And without, I suppose, any further ado, I will pass it off to our speakers for today.
Thanks, Anna, and welcome everyone. My name is Abhilash Desai. I'm a geriatric psychiatrist, part of the St. Alphonsus Memory Center, and there'll be 3 speakers today, so I'll speak for say 25, 30 minutes. Then I'll hand over the mic to Tiffany Robb. She'll introduce herself, and then she will hand over the mic to Mercedes, and then we'll have half an hour, we hope, to chat. We'll interact via chat, and we'll answer questions to whatever you guys put. We have all the answers. No, I'm just kidding. So we want you to also share your answers. So there's a lot of group wisdom and group knowledge that we can share and help each other out. So I'll share my slides and I'll be asking you some questions that please put the answers in the chat. The slides you received are much longer than the number of slides I'll use today. So you can go back to the slides and see there's more information there. All right, let's do this. So we'll discuss MCI and Alzheimer's disease and neuropsychiatric symptoms. All right, so aging is a privilege. So growing old is not a disease to be cured or defeated, but a privilege, tremendous privilege to be humbled by, to be grateful for. A privilege withheld from most of our ancestors and so many of our brothers and sisters. Let's become worthy of becoming old by falling in love easily, holding our heart gently, holding our fears lightly, and forgiving continuously. Feel free to comment on the chat, but it's important to realize there's a lot of ageism, and so if you guys can write in the chat how many potentially reversible factors you know that the research has shown to either delay the onset of dementia or reduce the risk of dementias, not just Alzheimer's disease dementia, but say vascular dementia. So the answers could be like 3 or 6 or 9 or 12. I'll also be talking about new tests to diagnose Alzheimer's disease and new treatments. So if you guys can write in the chat, what new tests have you heard that could diagnose Alzheimer's disease? And then you can compare it with what I'll be sharing. And then I'll be talking about something called the DICE approach and some other aspects of management of agitation, a research update. So if you guys can write in the chat whether you have heard of the DICE approach, have you heard of any other new treatments for management of agitation and neuropsychiatric symptoms. in individuals with Alzheimer's disease, dementias, and other dementias. All right. So let me start with a case. So this is from the website, National Institute of Health. Joe was almost 74. He was still working part-time. He noticed he was becoming more forgetful at work. He felt frustrated that it was so hard to find the right words to describe something. His boss told him that he missed a couple of meetings. He started to wonder if he had serious problems. And so wonderful wife said, all right, let's not take this lightly. Let's get a complete health checkup. Went to the primary care. Not all primary cares are comfortable. So maybe he went to a memory center. And there, the team told him that after a thorough assessment that you have mild cognitive impairment, MCI, and that there is no reversible cause. So he was glad to hear that. He joined the group comprehensive brain wellness program at the local YMCA. I know of a great program at our Tomlinson South Meridian YMCA, Movement for Memory program. If you don't know, you should know. And they have it. It's a group exercise program twice a week, costs around $65 a month. So check it out. And Joe also started using memory tools such as daily to-do lists, and he lived happily ever after. So the answer for how many modifiable factors are 12, which account for 40% of dementias. And so what are these 12 factors? One is early life secondary education. So if everybody received secondary education, I would say 700,000 less people will develop dementia in the next year. Yeah, that's true. Midlife, there are many other risk factors. A lot of these risk factors, by the way, also put you at risk of heart attacks, strokes, dying, prematurely. So we all need to do this, be aware of this, number one, and then proactively address each of these risk factors or help our family members, our friends, and the larger community really take a hold of that, like obesity, hypertension, hearing loss, air pollution, excessive alcohol consumption, traumatic brain injury, smoking. If you have any questions, again, put it in the chat. I can expand on these. Which of all these 12 modifiable factors, which do you think has the highest risk? Let's see what you guys answer. So the answer is hearing loss. So if hearing loss is eliminated in the entire human population, then 800,000 less people will develop dementia in the next year. Amazing, isn't that? And then late life risk factors are depression, diabetes, social isolation, physical inactivity. And then there are 3 potentially protective factors. So we can, if we are not doing this, we can start doing this even if we don't have risk factors or we've addressed all the risk factors that we can. Moderate to vigorous physical activity, best data, MIND diet, which is Mediterranean dash diet intervention for neurocognitive delay. It's just a fancy acronym. DASH stands for dietary approaches to stop hypertension. So again, we need a dietitian in the group chat to just answer any diet questions. And then frequent social activity. Ideally, obviously, it's in person, but a robust online, virtual, social life is also a good thing. And then this is my opinion. I think in the future, there'll be more research to support this. But, doing puzzles and all is important. But I would say, if you learn something new, language, musical instrument, and so forth, that will be very good for the brain. At least 20 minutes, if not more, of meditation, yoga, Tai Chi, Qigong, other relaxation exercises, prayers for 20 minutes a day would be protective. And then brain training with neurostimulation, some fancy programs also can help. And then, unfortunately, I have more potentially risk factors, right? So if you have chronic sleep problems, address it very seriously. Chronic stress. I know a lot of caregivers are experiencing chronic stress. If you have been on medications that have anticholinergic properties, so they block a neurotransmitter in the brain, acetylcholine, that is needed for memory and learning, and if you chronically block it, then your brain is going to struggle in the long run, and you'll start developing neurocognitive problems, memory problems, attention problems. Ageism, very negative bias, prejudices, and views about aging is not good for brain health, and pessimism. So let's talk about what is normal. So, if you get lost in familiar places, you forget the names of close family members, you forget what's happening on a day-to-day basis, that's not normal. Doesn't mean you have dementia, but you have to get assessed to find out why you're having this. Again, the frequency and intensity matter. Once a week is different from several times a day. You're forgetting appointments, important events, forgetting conversations, you're repeating yourself, saying the same story, losing keys, wallet, making all kinds of forgetfulness of paying bills, credit card, a lot of financial fraud you could be victims of, keeping track of a plot on a TV program, remembering short grocery lists. So all these, if they're happening frequently, that's a sign the brain is telling you to do something. Don't just assume it's aging or normal. Again, if you're not recognizing family members, forgetting to serve a meal just prepared, substituting inappropriate words. So again, you can have language problems along with memory problems, getting lost in one's own neighborhood, not recognizing numbers, putting iron in the freezer, rapid mood swings for no apparent reason, sudden dramatic changes in personality. So as you see, if you have memory problems along with other issues like, mood changes or even physical problems like falls and tremors, we have to take that very seriously. So we currently diagnose mild cognitive impairment, which another word diagnosis is mild neurocognitive disorder. We have criteria for that. So if in this case, Joe had expressed concern and his wife also noticed that he's been having mild decline in his memory and word finding difficulties. And then we got tested. They found that his office-based testing, like we do a scale called Montreal Cognitive Assessment Scale. He scored low based on his age and education, or even better, if we could send him to neuropsychological testing to get more detailed testing, you can be even more sure that the person has mild cognitive impairment and whatever problems they have is not normal aging and not dementia. And again, Joe could live independently, although he needed some extra time to manage everything. If they have functional decline, then they're heading towards mild dementia. And again, Joe needs to know that this is not definitely heading towards dementia in the future, although 10 to 15% people with MCI develop dementia every year. But a lot of people improve. We've seen patients with MoCA of, say, 20 out of 30. And then after 6 months, the MoCA was 25, which means the scores improved. And you could see that. And you could see static where there's just no worsening. So again, if they're doing all those healthy lifestyle and treatment of the risk factors, maybe we can have a much better trajectory. So let's talk about tests, because currently we have very fancy biomarkers that have come out, but unfortunately they are currently in the research setting. Currently, it's not like there is a test that will diagnose MCI or dementia. So it's important to know that it's a clinical diagnosis. You'll need a clinician who's trained and experienced in assessing and accurately diagnosing this. Again, when you get to the assessment, there are a lot of reversible factors that we can look for and treat. Polypharmacy in my clinical practice and obstructive sleep apnea are really common. as a cause, reversible cause of MCI and even dementia. So again, they have functional impairment, and you address all these, and they improve. If I had to diagnose Joe with MCI due to Alzheimer's disease, I would need a biomarker evidence. So let's say that he agreed to do a CSF test, cerebral spinal fluid test, and we had a place, a neurologist who was doing that, and the test showed that he had abnormal tests. For example, he had low amyloid A beta 42, or he had elevated phospho-tau in the CSFs. Then I would say that you're biomarker positive and you have MCI due to Alzheimer's disease. One could do a brain scan, like a fancy amyloid scan, amyloid PET. Unfortunately, currently in Boise area, we don't have that. We would have to send a lot of these patients to top-notch centers like Alzheimer's Disease Research Center, Brain Memory and Wellness Center at University of Washington in Seattle, and there are many other places. And there are other biomarkers that we could talk about. In next year, maybe, or even earlier, we might have blood biomarkers where if Joe comes and I do a blood test, and if the blood test shows elevated phospho-tau, then I would say you have MCI due to Alzheimer's disease. So that's another example. There are brain scans like MRI that could be done. It shows atrophy or loss of cells in certain parts of the brain, like the hippocampus. So, but it can't definitely say this is Alzheimer's. So it can help say that it's quite likely to be, but you need like CSF or blood tests or brain scans, amyloid scans, to say that it's Alzheimer's. And that's because we have this ATN classification. So you can do a brain scan, amyloid PET, you can do a CSF, and in the future, you do a blood test for amyloid. You can do a brain tau scan, tau PET, positron emission tomography. You can do a CSF tau, or you can do a blood test in the future. You look for neurodegeneration, which in MRI would be like atrophy. You can also do like FDG PET. It's another fancy brain scan that shows reduced uptake of glucose in certain parts of the brain. And it can help differentiate between Alzheimer's and, say, frontotemporal dementias. And then in the future, there'll be blood tests like neurofilament light or other tests that will show neurodegeneration. So let's say Joe had negative blood tests in the future and negative neurodegeneration, then I would tell him that most likely your mild cognitive impairment is not due to a brain disease. It might be more likely due to other metabolic factors, that we have identified. So these are the brain imaging biomarkers. As I mentioned, you can do cerebral spinal fluid, lumbar puncture. In Europe, they do this much more in US. And then all these fancy blood tests will be available. They're currently available, but insurance won't pay, and we're still figuring out how to assess it. So, nowadays people go to like 23andMe and get their ApoE genetic testing. And then I can imagine people doing some of these blood tests that are available commercially. All right, so that was new tests. Let's move on to new treatments for Alzheimer's disease. So there are two drugs that are approved by the FDA that are considered, they're called disease-modifying drugs, which means that they slow down the disease. They're not cure. And you might need more detailed testing, like ApoE genetic testing, prior to getting these drugs. Lecanemab is better than aducanumab. They have to be given intravenously every 2 weeks for 18 months. So a lot of things need to be lined up. And currently we don't have it in Boise. Even, the Brain Memory Wellness Center in University of Washington is preparing to offer lecanemab intravenous infusions. And currently, if you want to get these drugs, you'll have to take part in research studies, and then maybe 50% chance you'll be getting a placebo. Regarding side effects, they have serious risks like, bleeding in the brain and so forth. Some people are more at risk, like if you have certain genes like ApoE4. If you already are on anticoagulants, then maybe you shouldn't take it because the risk of bleeding is higher. There have been 3 deaths. The benefits are small, and so that becomes challenging. But this is such an emotional decision that I would support the patient and the family at whatever level they want me to support. They say it slows down decline, so you won't notice an improvement. And some experts say it slows down by 27%. What does that mean? Well, other experts say that it slows down by 4.5 months, which means that if, let's say, you were functioning at a certain level, then you will have a decline in the next 1 to 1.5 years, but you will be declining at a slower pace. So the people on placebo would decline faster by 4.5 months. Moving on to a new drug that has been approved recently by the FDA is brexpiprazole. It's an antipsychotic. Again, the benefits are very small, like the placebo group improved by 20%, and this drug group improved by 25%. And they measured agitation using a scale called Cohen-Mansfield Agitation Inventory. It's just a fancy scale which tracks. So the total points were, say, around 72 for agitation. And the placebo group improved by, say, 17 points. And the drug group improved by 21 points, so by 4 points more. And this was enough for the FDA to say that it's statistically significant, it's clinically meaningful, and we should approve it. Like all antipsychotics using in dementia patients, there is a black box warning for risks of strokes and premature dying. There are all kinds of other risks with this drug: headache, dizziness, sleep problems, even urinary tract infection, nasopharyngitis, and so forth. And it's costly, $50 a pill. So we can discuss more. And then another drug was approved a while ago for insomnia, again, very costly, but we can discuss more about when to use this.
Dr.
Moving on
Desai.
to the last phase of my talk, which is the DICE approach. So DICE is an acronym, again, stands for describes. If a patient tells me they have agitation, the family members, then I would ask them, describe what exactly is happening when you say agitation. Are they having like delusions, false beliefs that, somebody's stealing their belongings, hallucinations, seeing people coming in? Are they being physically aggressive, verbally aggressive? Are they pacing? Are they all kinds of other, I need descriptions. So that's D, as detailed as possible. Even a video recording is even better. And then I is investigate. So obviously the first step is to realize that there could be anything that could be causing this agitation. It could be infections, it could be, the caregiver approach. So we investigate together with the family and the team at Memory Center about what could be the causes. And in most cases, there are multiple reversible causes that you identify, then you create a plan to address them, so C, and then you evaluate whether that improved agitation. And again, in most cases, you can identify many reversible causes. You don't have to give any psychiatric meds. And you can get trained for this online. And then, as I mentioned, sometimes the caregiver approach can cause increased agitation. So a lot of caregivers can be trained to do the TADA method to help them tolerate the agitation a little bit longer, anticipate what the person is agitated about. Maybe they're hungry, maybe they're looking for pain medicine, but don't do anything to agitate them further. Very hard. So I know how hard this is, all right? So I'm not saying it's easy to not track, because we will be tracking a lot, but we need to reduce the amount of tracking we do, which is testing, asking questions to the person with dementia, reasoning with them. arguing with them, correcting them. Let's not do that. And then again, we can talk more, but we need to train ourselves as well as healthcare professionals in all areas of outpatient, long-term care, hospital, about how to change the way we interact so that we have good eye contact, our speech is softer, gentler, we touch them in a gentle way, and so forth. So I'll read this and then I'll be quiet for a few seconds so that you guys take this in. It's a little heavy. All right. So long-buried sorrow. What is her yelling? A sign, a signal, a symptom of moral anguish calling our souls to understand her plight. My patient had never learned to experience her feelings, as there was no one in her childhood or later who accepted her fully, who understood and supported her. And now with advanced dementia, long buried sorrow that could never be expressed is set free, and only touch and soothing voice can do the miracle of bringing her some solace. No meds, please, no meds. So let me share something else. This is a freely available book. And what does the book look like? Let's see if I can find it. Or not. There you go. So this is the book, and on page 89, here it is. I've mentioned supporting your loved ones' well-being in 5 ways. This is a superb book in general of how to live well with dementia. And we can talk more about, how to stay in the moment. This is more for the caregivers. Caregivers need to learn to try and validate the person with dementia's thoughts and feelings. Value their input if the person with dementia is saying something. And again, caregivers want to be perfect. We all do, but it's it's impossible to be perfect. And again, if you lose your sense of humor, you need to call me. I'll stop here and hand over the mic to Tiffany Ra.
Dr. Desai, before we pass it off to Tiffany, we do have one question for you in the chat.
Yeah.
It says, does anyone keep an updating algorithm for responsible diagnostic studies to diagnose dementia after a screening test is positive?
Yeah, so great question, and I would want that to happen, but honestly, healthcare system is so broken that just getting the basics is hard now. So forget this next level of information. But in research setting, we know that in the past, when we did not have biomarkers, even top-notch memory clinics were misdiagnosing Alzheimer's when 20% did not have it. And then when they had biomarkers, they said, oops, this person doesn't have Alzheimer's, although we diagnosed it. And this person whom we diagnosed with not having Alzheimer's has it. But yes, we need that. I agree. All right, Tiffany, take it away.
All right. Hello, everyone. Let me go ahead and pull up my slides, and please forgive me. I'm working from home today, and of course, somebody is using some sort of saw thing outside of my window. So my name is Tiffany Robb, and I'm the program manager for Alzheimer's disease and related dementias program that's embedded within the Division of Public Health at the Department of Health and Welfare. My program was started in 2021 through legislative act when Idahoans had determined through a legislative report that we needed to improve the way that Idaho responded to and addresses Alzheimer's disease, brain health, and dementias. And so what I'm going to do is kind of provide you a little state of the state. And so here, what do we know? Currently, there is no cure for dementia. As Dr. Desai had said, there are some symptoms that you can be experiencing that can be reversed, that if left untreated could go into a dementia state. But currently there is no cure. We have those medications that can slow and delay, but we need to figure out how to best respond. We also know in Idaho, 9.8% of Idahoans 45 years of age and older had reported a subjective cognitive decline. That means that their memory in some way or their cognition is interfering in some way or capacity in their daily life. The other thing
we are not seeing your slides if you're showing some.
That'd be really good for you to see them, wouldn't it?
Well, I like looking at you, but just
I'm
Me
totally
too.
out of it. This is great. Let me try this again. Please forgive me, everybody. My brain is stuffy. Okay, let me share my slides with you and let me go through that again. They're a lovely deck. I think you would appreciate them, maybe. Okay, so let's start at the beginning. And there we go. Are you seeing the full slide deck this time, Sarah? Nice. Okay, let's try that again. Here's this lovely picture. Here's my stat. So then you can read along with me instead of looking at my face and hearing my clogged, stuffy nose. So anyway, we also know that people with dementia or who have a diagnosis of dementia throughout the course of their care and life will end up needing 2 to 3 more caregivers than a person of similar age who does not have a dementia diagnosis. And I'll bring up more on that later. We also know, according to national data, and Dr. Desai touched upon this, that 50% of primary care providers were not prepared to care for this Alzheimer's population that we currently have, and 39% are not comfortable providing an Alzheimer's diagnosis. Again, I'll be touching upon this in a little bit. So here are some Idaho statistics specifically for you to digest and understand the reasons why Idaho found that we didn't have a good response to Alzheimer's and dementia and brain health, and why we needed to build a more robust system. So in Idaho, we know that currently we have 27,000 Idahoans with a diagnosis of Alzheimer's. We have 65,000 Idahoans who are providing unpaid care to someone with an Alzheimer's disease. We know that less than 50% of those individuals, that 9.8% who are reporting subjective cognitive decline, are actually talking to their healthcare provider if they're experiencing that, which is quite concerning, because as you learned from Dr. Desai, if you go and talk to your healthcare provider when those concerns come up early, they may be remedied or delayed if at all possible. And then the big thing that we just know is that Idaho does not have a robust system to provide that adequate care for a person with dementia or their caregivers, which again, these are some things that I'll be touching on throughout my presentation. So with the program being started in 2021, there were quite a few tasks that we were responsible for accomplishing. One of the big tasks and big achievements, I think, is the development of the statewide ADRD Alliance, which is the Idaho Alzheimer's Disease and Related Dementias Alliance. You'll see the logo here with the tree. And this alliance is a statewide alliance. These are individuals and organizations all across the state who have come together to help us improve our response in Idaho. In the middle of the screen, you're going to see the strategic plan that the Alliance had developed for 2023 to 2028. And then over on the other side of the screen, you'll see this nice little logo that says Dementia Friends Idaho. And I'll give you more information on all 3 of these in just a moment here. So as I said, one of our big responsibilities as a program was to stand up an ADRD or an Alzheimer's disease and related dementias alliance. Why? Because we needed to hear from Idahoans how best to improve Idaho's response to Alzheimer's and dementia. As I said, this alliance is statewide. We have over 180 plus alliance members who participate whenever they can in the alliance meetings. And again, there's state representation from all of our 7 public health district areas. We're super happy to have 5 of our 6 federally recognized tribes participating in this alliance. And we're super happy that, that the alliance is not closed off to specific entities and organizations. This is an open forum for individuals, no matter what your education status, ethnicity, whatever, come and join because we want you to have a voice and we want you to influence the care that you or your individuals that you're caring for can get here in Idaho. The ADRD Alliance currently is meeting on a quarterly basis. And one of the big responsibilities that the ADRD Alliance is assisting with now is working together in teams to track what Idaho is doing across the state with 7 strategic or critical success factors, of which I'll be going into here. So as I had said, the ADRD Alliance had developed a strategic plan for 2023 to 2028. In that strategic plan, they identified 7 critical success factors or areas of focus that they felt was most important for Idaho to improve our response to brain health, Alzheimer's, and dementia. Now, the first one you'll see here is brain health and wellness and early benefit or benefits of early detection. Again, as Dr. Desai had said, there are risk factors that we know that we can change throughout our lives that reduces our risk of dementia or can even delay the symptoms if we're already experiencing those. We want to educate and empower Idahoans with that information so that they have a choice to improve their brain health and wellness. The next one is the actions to improve quality of life. Of course, many individuals who have received a diagnosis of Alzheimer's or dementia or their families who are right there beside them who have received that diagnosis would say, how is this and how can you improve quality of life? Well, we cannot improve the prognosis, but we can provide you the information and the education to empower yourselves to improve the life that you have that's set forth in front of you. If you receive an early diagnosis of a mild cognitive impairment or Alzheimer's or dementia, and you have the information in front of you that can help you determine the type of care that you would like to have when you no longer have the cognitive capacity to determine or direct that, this is an opportunity to improve that quality of life that you are providing or being provided. And there are other areas there that we can help improve on. The other thing that you'll see here is training of healthcare professionals. As you saw from that one statistic with the 50% of primary care providers who just were not prepared for our Alzheimer's population, why is that important to us and why is that important to us in Idaho specifically? Well, in Idaho, we have 8 geriatricians. That means that we rely heavily upon our primary care providers to help individuals receive a diagnosis and navigate the very, very complex system to get the services and supports they need. So what we are working on is working with our stakeholders across the state to improve education and awareness for healthcare professionals so that they feel confident in providing that diagnoses and assisting individuals in navigating the system. Now, of course, we can't just focus on our healthcare professionals because our community needs some education on Alzheimer's, dementia, and brain health. Why? Well, let's empower Idahoans so that they can reduce the risk of dementia ahead of time, since there's currently no cure for it. And really, it's not like Alzheimer's and dementia just popped up and we're just now trying to find a cure. This has been going on for a very, very, very long time, and we still don't have a cure. So let's be proactive and work on those risk reduction factors. But let's also have conversations about dementia and Alzheimer's. Let's make that conversation a norm so that we can reduce the stigma that surrounds Alzheimer's and dementia, that ends up having individuals who have a diagnosis and their caregivers isolate, which we know after surviving a pandemic, isolation is just not healthy. We need to have that human contact, that socialization that Dr. Desai was talking about. And so we need to educate Idahoans on how important the conversation is around dementia. Now, another thing that we really want to focus on, or that the Alliance had determined was important, is we need to support caregivers. As you had seen from an earlier stat, 65,000 Idahoans are providing care to someone with Alzheimer's disease currently, and that's unpaid care. Now, many Idahoans don't expect to be paid to provide the care that they're providing, and many Idahoans actually are honored to provide the care that they're providing to their loved ones. But we as a country and we as a state can stand alongside caregivers and provide them the support and care for them so that they can provide the care and love that they need to for their loved one. And that's something that the Alzheimer's or the ADRD Alliance has determined is very important that we look at. Now, there's two other ones here. Number 6, you'll see here is the equity enabling factors and systems, funding, etc. There's a lot bundled into this. We really want to make sure that the information that we're putting out there to our community members, the supports that we're providing to our community members, the funding opportunities, don't just serve one segment of our Idaho population. Our Idaho fabric is a beautiful tapestry of many ethnicities, genders, and beliefs and cultures. And we have to make sure that the support, services, funding opportunities embrace all Idahoans so that they can get the access and services and supports they need. And of course, number 7, strengthening workforce. If you've survived the last 3 to 4 years, you know we've got workforce issues. Part of that was COVID, but part of that is exacerbated by the fact that our boomer population is retiring out, leaving many vacant seats. Why is this important? Well, we rely upon, and our population with dementia and Alzheimer's definitely relies upon our healthcare industry, our physicians, our healthcare providers, nursing, PAs, the whole bit. But what our population really relies upon, if you remember that one statistic with an individual with an Alzheimer's diagnosis relies upon 2 to 3 more caregivers per, those are direct care staff who are probably coming into the house and who are probably not getting paid a whole lot and may not even be getting benefits for the hard work that they're doing. And so we are suffering a very severe workforce shortage in that area, and something that the Alliance has determined is very important for us to focus on. Now, I want to bring up Dementia Friends. This is the last one that I'll bring up for today because I want to give an opportunity for Mercedes to talk and share resources and information. Dementia Friends is a program that we have brought to Idaho. We're super excited about. And for the last 6 months, we've been piloting it through our ag extension offices across the state. The reason why we wanted to pilot it was to see how receptive to the program were Idahoans. Did the program serve Idahoans' needs? And is it good for Idaho to continue offering this free program in our community? Currently, we have 6 Dementia Friends champions. Those champions can offer education or information sessions. Those information sessions are a bit of what Dr. Desai had provided on those signs and symptoms, but how you also respond to a person with dementia, as well as how to create a dementia-friendly community, thereby tackling that stigma of dementia in our communities. Currently, we have 181 Dementia Friends across Idaho. We're super excited about that. And the sessions themselves are 60 to 75 minutes long. They are free, and again, they are offered through our dementia or our University of Idaho Ag Extension offices across the state. We do have a Dementia Friends website to where you can go to the map and find your instructor close to you who can offer that for a group that you would like to have provided, or join maybe a virtual group if you would like to as well. One thing that I really love about this program is the fact that when I was growing up, and if dementia were around, as a child, I wasn't brought into the conversation. Usually it was a hush hush, which really exacerbates the stigma around dementia. We know, though, that children are co-caregivers in many of these situations. And in Idaho, we're very reliant upon our kinship providers or grandparents who are taking care of their grandchildren. And those grandchildren may be seeing some of this cognitive impairment going on in their main caregiver. And so we've got to start educating our youth about this. And so Dementia Friends can be, the information sessions can be provided to anyone 5 years of age all the way up. And with that, I just want to leave you with this, which is our slogan for the ADRD Alliance. As you've seen from the data and information, and if you're very well aware of our state, we do really well coming together in our state to work and tackle issues. And in Idaho, as long as we have all of you coming together and our alliance being as strong as it is and continuing, we do take this journey together, and we will improve Alzheimer's, dementia, and brain health in our state. And with that, I'll leave you with a few links here and then turn it over to Mercedes.
Thank you so much. First of all, I just want to express my gratitude for inviting me to be here in this virtual panel with all of you. And let me go ahead and share my slides. Oops. Can you all continue to see my slides?
Not yet.
Okay, it looks like Zoom quit on me. All right, can you see my slides now?
Yes.
Fantastic. Sorry about that. Interestingly enough, we've been in this virtual world for like over 2 years, and we still experience technical difficulties. As I was saying, thank you so much for inviting me to be here in this virtual panel with fantastic presenters. And I will go ahead and begin my presentation. So oh, there we go. Sorry. So I am excited to be here for a variety of reasons, because I truly association. Not only do I get to live out the mission, but I'm also connected to the disease because of my grandmother. My grandmother was not officially diagnosed with the disease, but it was a time when we just didn't talk about it. We just didn't have language around it. And I saw how my family struggled to provide support and assistance to her. So now I get to create programs that support families during this difficult time. So what is the mission of the association? The mission of the Alzheimer's Association is to become a leader in the way to end Alzheimer's and all other dementias by accelerating global research, driving risk reduction and early detection, and maximizing quality and care and support. So I love our vision because our vision is simple, but it's one that is super lofty. And ultimately it is to live in a world where Alzheimer's and all other forms of dementia no longer exist. So how do we operationalize our strategic goals? So we do this through 6 different pillars. Each chapter is responsible for implementing activities that will reach our goal of enhancing care and support and research. So the providing and enhancing care and support is a pillar that I oversee, which is, I often call it as the heart of the association. We are responsible for providing education programs in the community, and we are also responsible for providing support. And the way we do that is through support groups. We are able to provide these education programs in person or online. They're also available through our website, and people can complete the training on their own pace. But if you're ever interested in having a lunch and learn, just contact me. We'll be happy to present to your staff or to go into the community and do presentations there. Okay, so the second pillar, and it's in no order, is accelerating research. So we are one of the largest nonprofits that invest resources to find a cure for Alzheimer's. If you're interested in participating in that, please visit our website, trialmatch@alz.org, and they will be able to match you with a study. Currently in Idaho, we don't have any particular studies happening here. However, that doesn't mean you can't participate, because you could join virtually or through phone. So while we don't do the bulk of the research studies here in Idaho, that doesn't mean that you cannot participate.
Mercedes.
Yeah.
I am still seeing your very first slide. I've also gotten one message that somebody's seeing it as a black screen.
Oh. I keep on getting like that Zoom has disconnected me messages. So let me try again.
I'm now seeing your strategic goals slide.
Okay. I'm seeing Sarah. I'm not. Okay. Thank you so much for letting me know. All right. So we've already covered the accelerating research and increasing concern and awareness. Yeah, and I'm still getting the Zoom quit unexpectedly. Can you see my slides still?
Yes, I can still see them.
Fantastic. I keep on getting this pop-up message, which is the first for me. So my apologies. So what are the things?
We can just request her to use, just share her thoughts without the slide. That'll be easier. We are all low key, and
And Mercedes, if you want to email me a copy of those slides, I will get them out to all of the attendees as well, so they can look through them later.
Mercedes, you're muted.
That's a first for me, but this is happening. So yeah, apologies. And we will send those out to the team. So let's see. Increasing concern and awareness, which is, we know that this disease still has a lot of stigma associated with it. So what we want to do is work through various media outlets to keep it on people's forefront and to continue talking about the barriers, the gaps to services, and how we could support families that are going through this process. So the other DEI, the other pillar that we work under is diversity, equity, and inclusion. Ideally, this pillar needs to be fused within all the pillars. However, it is a pillar that I oversee, and the way I am operationalizing it is that every year we have about 5 community forums with communities that often go underserved. We've done community forums with the Latino community, the African American community, and with the Shoshone-Bannock tribes. And what we want to do is to go to the community, find out what those gaps are, and adapt our services to better serve them. We know that African Americans are overrepresented when it comes to this disease, and the same is true for Latinos when compared to their white counterparts. Another pillar is public policy. We have a team of one, Lisa Anderson, who every year identifies 2 to 3 priority policies, and she works with our legislature to advance services and supports for people with living with dementia or their caregivers. And the last one, which is probably how some of you have gotten familiar with our organization, is funding. So every year we have a walk, and that is our largest marketing revenue, and about 80% of what we make goes back into the association in finding a cure, delivering programs, and policy priorities. Let's see. I also want to talk a little bit about some of our services that we provide to the public. The first one is our helpline, which is 1-800-272-3900. This helpline is open 24/7. We don't close on major holidays. So when we say 24/7, we really do mean that. The line is answered by master level clinicians that have undergone extensive training before they even take a call. They are able to answer calls in over 200 languages. And the people receiving the calls are folks within the United States. Anybody could call the helpline. It could be the public, it could be families, it could be paid or unpaid caregivers, and it could also be people living with dementia. I already briefly mentioned our education programs, but I want to repeat that again because we do offer a vast variety of programming, from the, kind of like the foundational education, understanding Alzheimer's and dementia, 10 warning signs, to the more specialized presentations, which include dementia conversations, understanding behavior, and healthy living for your brain and body. And my last slide covers how you could help. Some people have been impacted by the disease and therefore want to give back. So if you are interested in becoming a volunteer, feel free to reach out to me. I will put my contact information in the chat box, and we will find a fantastic pillar for you to share your gifts and talents with us. And that is the end of my presentation.
Thanks, Mercedes. We have Dr. Taves here, so I'm going to put her on the spot to give us her thoughts and 30,000-foot view.
Well, to our team of presenters, thank you. And for the individuals in the audience, we really appreciate your engagement and you thinking of, not only where your current situation takes you, but how you plan for the future. And I really appreciate Dr. Desai's first slide about the, kind of the honor to age. And how we all need to recognize and appreciate that process for ourselves and those that we are caring for, as well as those that may be caring for us in the future. So I encourage you to keep these resources for reference and to keep your eyes open for other events that are coming up as well. This is an ongoing series. It will certainly be something, I mean, I think the whole support and opportunities to delay the onset of dementia are important to all of us, and staying together, staying connected, continuing to build our network of friends and support is critical in that prevention and delay activities. So again, thank you to our presenters and to all of you who attended, and for Hannah Shifley for her brilliant organizational skills. Really, I'm delighted to see how folks are using the chat as well. I think at this point, if you have other comments to share in the chat, we'd love to respond to those. So thank you very much.
Thanks, Sarah. And again, we have a lot of experts and expertise in our attendees, Sarah. So I'll put a few on the spot. One is Dr. Steve Montemat, my friend. So Steve, if you can unmute yourself and give your thoughts, guidance, wisdom, please.
Oh, thank you, Abhilash. Yeah, I'm not going to do my video. I'm suffering from a pinched nerve right now. But I'm just amazed at what all has changed in the last 15 or 20 years. I can't remember when the first report from the Idaho legislature came out about the needs in our state for care of patients and their caregivers suffering from Alzheimer's. So it's just great to see all the activity and all the participation. I think it's also very exciting to see the changes that you showed in the diagnostic capabilities we have. I'm the one that posed the question about being responsible, because we know in other areas that testing can go crazy. And just like you said, there are false positives and false negatives for any kind of test that we have. So we got to be careful about that use. And then I'm also, as you know, excited about some of the treatment options, but again, they have to be weighed against the potential side effects and the costs, and so what is the overall utility of these agents? So it's a very exciting time, and anyway, I'm just happy to see so much participation.
Thanks, Steve. We have again a few experts. I'll put them on the spot. So we have two social workers from Memory Center St. Alphonsus, so Kathleen and Katie. So let's put Kathleen on the spot first. Any thoughts from your perspective that we should share with everybody? Maybe she hopped off. And Katie. All right, they may have to have hopped off. So anyway, any other questions we can address? Because I have a lot of things to say, and I'm not going to let you all go.
I just want to say this information is extremely valuable, and I'm wondering if how much of it can be public and just kind of like sent to the community. I'm thinking of just like some of my family members and stuff who like learning about Alzheimer's and just going over to Dr. Desai's presentation, all those the ways to kind of to ward off Alzheimer's, I think would be great recommendation. And as we learned about in here, it's just a lot of our community members just aren't really aware of the disease and how to ward it off. So I don't know if maybe like if there's a YouTube presentation or something that we could share and publicly, that would be great.
Yeah. So I've listened to a lot of podcasts and YouTube presentations, but whatever I've listened to is more directed towards clinicians and healthcare professionals. But I totally agree with you. I think the key, as Tiffany mentioned, was empowering all public, all of our friends, family members across all age groups, as you mentioned, on brain health literacy, right? And that would be part of the health literacy, right? Like, all the basic information about health and importance of exercise, diet, and medicines, and so forth. And to me, it's never too early. So we need to have a lot of these things start in school. A lot of schools now talk about, diet and exercise, and some of them talk about relaxation exercises, and you can expand on that and then keep increasing the sophistication of information and expectations so that all of us become really savvy humans in terms of health and living well. And also then when we interact with primary care providers and other healthcare professionals, we start off at a whole different level, so that limited time that we have with the healthcare professionals can be used much more effectively. Does that make sense, Adrian? Yeah. And again, students have to come up with all kinds of creative solutions because our healthcare system as it is currently functioning is really struggling, and primary care providers just don't have the time that, you and me and everybody wants them to spend. But that's because they haven't been given the kind of support to provide the care that I believe they can deliver if they were allowed to just focus on the outcomes and not like how many patients you're seeing in the billing, Anyway, maybe I'm digressing, but thank you,
Dr.
Adrian.
Desai, on that note, Laura has asked if you could possibly share more about normal cognitive loss with aging.
Yeah, so again, I joke that, there's no such thing as normal cognitive loss with aging, because it is a reflection of the life we have led until then, So if at the age of 70, if you've had a different life trajectory compared to another 70-year-old who has led, like, let's say they've been more physically active, they're eating Mediterranean diet for a long time, they have taken care of their blood pressure so that their systolic blood pressure is, when they were in their 50s, is less than 120. If they have depression, they're actively taking care of that. Then, their brain will function at a much higher level. So they won't see the slowness in processing, all right? So that's one of the things they mentioned with aging, is that the processing speed slows down so that you have to, it takes longer time to digest information. It's harder to do multitasking. So that would be normal part of aging. If you have occasional word finding difficulties, especially for words or names of people that are not regularly encountered, then again, that would be normal part of aging. But a lot of it also depends on, the frequency, as I mentioned. For example, there was, there have been studies to show that people can detect subtle levels of decline, what is called subjective memory complaints, SMCs, or subjective memory decline, years before you develop mild cognitive impairment. So at that time, you could say, that same Joe, right, 74 years old, let's say he had all these memory complaints, but he tested normal in those tests that I mentioned. You have to test abnormal to say you have mild cognitive impairment. Let's say he tested normal. Then I would tell him that you don't have mild cognitive impairment, and obviously you don't have dementia. You have what is called subjective memory complaints. And then let's say he asks me, is this related to my age, 74? I would say yes and no, because we know that Alzheimer's disease starts 20 plus years ahead, right? So we currently have research studies going on in these individuals who have subjective memory problems. And some people could say that could just be normal part of aging, but they have positive biomarkers for Alzheimer's disease. So they have either brain scans positive or CSF or blood tests. So these could be going in the direction of mild cognitive impairment down the line and eventually to dementia. So in the group of people with, quote, normal age-related memory problems, you have a subgroup. It's a much smaller group, all right? So say out of 10, maybe 1 or 2, that might be the earliest sign of Alzheimer's disease. And these people now in the future will be taking part in research where they will get medicines because, as I said, they have biomarkers positive for Alzheimer's disease. So let me stop here. I may have made it more complicated. But again, it's better to see memory problems, forget age-related. It's best to see them as, all right, is the brain telling me that I need to radically alter my attitude, my lifestyle, my priorities, so that brain health and wellness becomes my top priority.
That was great. Thank you. Another question in the chat asks, what initial screening tool do you prefer to use for MCI and dementia?
Right. So again, all these are very well researched. So that's good news, So let me share the screen, and I've been prepared for this. So let's see. All right. So one of the screening tools, let's say you go for a wellness visit, annual wellness visit, you can bring this. This is available freely on the internet. You print it out, you fill it out, and you say, listen, I've had memory problems in the last 6 months. I'm forgetting things, I'm misplacing things, but it's a no to all these questions, 88. So I'm not having any problems with decision-making or finances. There's no change in my interest or hobbies. I don't have trouble learning about new tools. I don't forget, correct month and year, handling complexes. So this is one tool that I would do in primary care. Then let me open up another one, which is Mini-Cough. So if, let's say I'm doing a screening tool, all right? So 88 was, say, 0. Obviously, if it is 1 or 2, I would be more worried. But I also will do, say, a 3-word recall. So I would ask them 3 words. I would ask them to repeat it right away so that I know they have retained it. Then I would do a clock drawing test. I would tell them, I'll make a circle, and I would tell them, put in all the numbers and then have the hands show 10 past 11. And then I would score them. And let's say the clock drawing test or the 3-word recall is abnormal, all right? So the total score is 0 to 3, and they don't score well. So normal clock would be 2 points, and they recall 3 out of 3 is 5 points. So and the cutoff is less than 3. So let's say they score a 2 on Mini-Cough. Then to me, that was abnormal. So then they screen positive for significant memory decline that requires a more comprehensive assessment. So I would have them come back for like a 1-hour, assessment to assess whether this is mild cognitive impairment or dementia. And in that assessment, I would go much more detail into the history and So I would ask Joe, so when did all this start? Okay, a year ago. Did it start suddenly or slowly? They'll say slowly. Was there a stroke before that, or no, nothing like that? Was it a traumatic brain injury? No. So I would go to very detailed history, and from the person, patient, as well as the family members. And then I would do a thorough physical exam, neurological exam. I would look for any tremors, any unsteady gait, all kinds of other neurological abnormalities. I would do a detailed mental status exam, looking for any depression or anxiety, because depression can look like dementia, but it's not. And they can have all kinds of attentional memory problems. And then I would do this Montreal cognitive assessment. So I would, or do all these tests, language, abstraction, attention, executive function, and let's say that they score like, say, I expect them to score like 27, 28, 29, 30, and they score a 20. So now they're saying that there is a decline in memory. The family members are saying that. In my mental status exam, I didn't see any severe depression, anxiety. The neurological exam was normal. The Montreal cognitive assessment was obviously abnormal. If I have a chance, I would refer them to neuropsychologists. Ideally, they would get a much more detailed testing than just MOCA, but they're busy and they're full, and it might take like 3 months to get an appointment and all that, and the insurance has to cover and all. Anyway, so, but again, this just shows that they have, say, either mild cognitive impairment or early dementia, depending on their functional impairment. So another scale, let me see if I can share, is called FAQ, Functional Activities Questionnaire. So this is the main scale I use to measure their function, all right? So, and I give a score, 0, 1, 2, and I'll have family members fill them out, patient fills them out. Sometimes patients give themselves a better score than the family members. It is what it is. I would do that too. I would give myself a higher score. But let's say that so they have impairment in all this. So now that you have memory decline, you have abnormal test in your cognitive testing, MOCA, plus you have functional decline, then I would say that they have mild dementia. And why mild? Let me share another scale, which is stages of dementia. There you go, 7 stages of dementia. Stage 1. So just for you to know, my wife thinks I'm in stage 3, because even though I don't think I have memory problems, she's seen it. I'm just kidding. So stage 1 is no memory impairment. Stage 2 is very subtle memory problems, like that subjective cognitive decline I said, and you have biomarkers positive for Alzheimer's. Stage 3, stage 4, stage 5, stage 6, severe, stage 7. So I would say that, you have mild dementia, stage 4. And again, each stage is very long. So you can have mild dementia early, and you can be in stage 4 for like years, especially if you're doing all these exercise, nutrition, Mediterranean diet. But that's just dementia. It's an umbrella term saying that there's something wrong. And what's the cause? Remember, there are all kinds of causes, So I would do an MRI of the brain. If the MRI shows multiple infarcts, I would say you have multi-infarct dementia. Let's say the MRI shows strokes, and I have a fancy biomarker test that shows positive for Alzheimer's, I would say you have mixed dementia. If, let's say, they have Parkinson's disease and now they're developing decline, I would say they have Parkinson's disease dementia. Let's say the depression score was very high, then I would say, this could just be depression looking like dementia. I would treat them, and believe it or not, I have, quote, reversed Alzheimer's. Obviously, I haven't. They had depression, I treated it, and their memory improved. So obviously the depression was causing the memory problems. And I can go on and on, like you can have normal pressure hydrocephalus on the brain scans. Then I'll tell them, this is not Alzheimer's, this is not brain tumor, you need a neurologist to see you. Maybe you need a neurosurgery for shunt, for hydrocephalus, so that'll be another example. Obstructive sleep apnea, vitamin deficiencies, thyroid dysfunction. So I do all this comprehensive assessment before I give them a diagnosis of, say, neurodegenerative disease, most likely Alzheimer's or probable Alzheimer's. And then obviously a full treatment, brain health wellness plan, medications, support groups, community resources. All right, let me stop here.
Dr. Desai, I'm delighted that you ended that conversation with this notion of thinking about the external environment or the surrounding environment. I think that is the other assessment that needs to be continually occurring, and the conversations between family members with community supports that are there, say a pastor, a faith leader that is close, that is connected to the individual, as a way of, again, as Tiffany mentioned with Dementia Friends Community, trying to normalize this occurrence of change in cognitive ability. And
Right.
I think for the family and those close social circles, just to really work on the communications between those partners is key, so that folks are feeling informed and are able to be supportive in a way that's supportive for the individual. So again, I think this focus on the individual with the condition is certainly, important and critical, but we also need to step back and take a look at that environment and make sure that we're doing everything we possibly can to kind of diagnose the health of the environment that's surrounding the individual and have those challenging conversations often.
No question. And also they could be higher determinants of their health, brain health and wellness. So we have like biopsychosocial spiritual approach, right? So biological is all these medications and tests. Psychological is, relaxation exercises, yoga, and sort of avoiding negative thought patterns. Social is what you're talking about, where, if you enrich their environment, their interpersonal and physical environment, like nature, everything else being same, the brain function will skyrocket. It'll improve dramatically. And again, the caregivers, if they get the support, then they will be less depressed, less stressed. That itself will improve the person with dementia's well-being. So yes, no question. Even the best of institutions like Massachusetts General Hospital has clearly stated, for brain health, the approach needs to be biological, psychological, social, and spiritual. Others can just unmute now and jump in and give comments or praise. I'm just kidding. Come on, if you guys know somebody in the group, you can just point them out. I have no hesitation.
I also see we have Sister Anthony Marie from Idaho State University on the call, and they have a very powerful, important geriatric certificate that I'd love to have her celebrate and promote and inform.
Sure, you read my mind, Sarah. On October 11th, we're going to have the Thomas Geriatric Symposium that we have had before we had COVID. And we had over 600 to 800 students, along with 100 elderly people who joined in the symposium by just sharing what it's like to be older. But this year, we're going to celebrate and talk about dementia. And so the older adults teach the students of all disciplines within the health sciences about Alzheimer's, caregiving, and so forth. So on October 11th, we're planning and finished planning almost. We're never finished planning. But anyway, about students who will learn more about dementia and all the environments that an older person might be going through as far as caregiving goes. So that's exciting for ISU, but it's also exciting for the state of Idaho.
Fantastic. Anybody else? Speak now.
Yeah, I got a question for you. My name's Tina.
Hi.
Hi. I know there's over 400 different types of dementia, and I'm dealing more with chemo brain right now with an individual. So I'm kind of curious on the possibility of dementia forming.
Yeah. So obviously, I don't know you well enough to give any specific, comment on your specific risk. But in general, we need to realize that anything that negatively affects the brain, right? So it reduces their brain cells, brain connections, brain function, will put you at higher risk if you have other risk factors for dementia. Same things that will benefit dementia, like exercise, Mediterranean diet, socialization, meditation, will help anything that is negatively affecting the brain, including chemotherapy. So the best way to see the brain complaining that I'm not remembering correctly, I'm not paying attention, is as you're doing, identify what could be causing it. But remember, there could be more than one cause. So your primary care provider can get into more details of what could be, identify every possible reversible cause, not be satisfied with just one. And then create a brain wellness plan. And then you'll have to actually implement it every day. And ideally, you should have sort of support system or peers helping you with that, So another thing I want you guys to take home is like the 3 pillars of chronic brain health problems. One is self-management. How do we manage ourselves? We need to improve upon that. Stress management, time management, and so forth. The second is peer support. So I'm sure there are a lot of other people with chemo brain, and they might have been there, done that, and they can give you way better advice than I could. So you need peers in your area. So if you have frontotemporal dementia caregivers, you need that peer, which is very different than Lewy body dementia, which is very different than Alzheimer's, than strokes, and so forth. And then you need access to experts. So that's when, the whole current health system creates problems. But in the future, there'll be innovative programs which will get you access to experts. And experts can just give you what to do, and then how to make it happen is where the peers and your family members and your own sort of things can make that happen. But great question, and thank you for being brave and asking. All the best to you.
Well, actually, I do have a Facebook group called Idaho Caregivers Unite. And thank you. And it's for all caregivers, doesn't matter what disability it is.
There you go. And then these are the things that are going to improve our future, right? We should look for government, but check for your expectations. Same thing. We can look for healthcare systems, but maybe lower your expectations. But we need to come up with something very radical from the ground up. All right.
There is a couple of classes you can take online from New Zealand.
Wow.
It's the MOOC.
Yeah.
And one of them is Understanding Dementia.
There you go. So MOOC, for those who don't, is massive open online courses. So I've done a couple of MOOCs. They're great. So thank you. And we could go on, but let me stop here and hand over the mic to Hannah.
All right, everyone, we have reached the end of our time, and I just want to say thank you so much for joining us and for actively engaging in the chat. If you want to just keep an eye on your email, we will be sending out the recording of this session as soon as we have it available. We'll also be sending out a survey at the end. We want your feedback because We're hoping to run more little pop-up events similar to this one, and we really want to know how you felt about today's content and what we can do to improve. So on that note, I'll just say a final thank you to all of our presenters who gave us such great information today. And I think that's it. Thanks everyone for attending and participating. Have a
Thank
wonderful
you,
week.
Hannah. Thanks, Sarah. Thanks, everyone. Ciao.
Thank you.